Hi, everyone. Thank you so much for coming and welcome to Stanford Care's monthly community health talk series. My name is Yuna Kim, and I am a second year PA student here at Stanford School of Medicine. I am pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. Today, we are welcoming Dr. Deborah Kado, who will be speaking on secrets to longevity, what we can learn from Asian American aging. You might be wondering, why do some people live longer, healthier lives? And what role do culture, lifestyle, and community play in this equation? Dr. Kado, a nationally recognized expert on aging and health disparities, will address these questions in our special Stanford Care Community Health Talk on Asian American longevity. Drawing from both research and clinical insights, she will explore aging trends in Asian American populations, highlight key factors that contribute to healthy aging, and share what we can all do at any age to promote better health throughout our lives. Dr. Deborah Kado is a board-certified geriatrician and professor of medicine at Stanford. She co-directs the Stanford Longevity Center and leads research in the Geriatrics Section in Stanford's Department of Medicine. Additionally, she directs the Geriatric Research, Education, and Clinical Center, also known as GRECC, at the VA in Palo Alto. Her research focuses on aging, bone health, osteoporosis, and hyperkyphosis, a condition she helped define as a geriatric syndrome. With over 100 peer-reviewed publications, she has received continuous NIH funding. A California native, she trained at UCSF and UCLA, where she also earned a master's degree in epidemiology. We are extremely grateful to have Dr. Kado with us today. So without further ado, I'll let Dr. Kado take the stage.
Well, thank you so much, Yuna, for a kind introduction. So I'm going to share my slides and hopefully get it right. The first thing is business. I have these following disclosures, the main one being that I am a federal employee, so that I just need to state that these views that I'm expressing tonight are my own and do not necessarily reflect the position or policy of the VA or the United States government. So in 2025, a baby born today may expect to live a century-long life. And that's amazing. In fact, today there are over 100,000 centenarians in the United States. So this is really a realistic expectation, which has never been seen before in all of human history. Today, though, we're going to focus on Asian American aging. And who are we talking about? And the idea of aging, it's such a popular thing now, I think, because the world is getting older. So on the left-hand side, you can see between 2000 and 2050, the world population in billions is just increasing kind of exponentially, especially for those over the age of 60. And increase relative to others, it's really and it's the older age population that is growing the fastest, such that by 2035, it's estimated in the United States, the number of people over the age of 65 are going to outnumber the number of people under the age of 18. Okay, in 2023, Asians are also increasing in terms of the numbers here in the United States. And as you can see from about 2000, where there are 11.9 million, we've doubled by 2023, such that we're making up about 7% of our population in the United States overall. And you can see those numbers in the bar graph above. And as of 2023, they're now including Central Asians. So we're broadening our reach. Okay. And maybe no surprise to everyone, but here we are in the state of California, and we have the largest Asian population of any state in the United States, about 7.1 million people. The next four states in order are Texas and New York with about 2 million people, New Jersey, which is really small, you can barely see it over here, 1 million, and then the state of Washington comes in at number 5 at 990,000 or so. So that's American Asians, foreign born and born here. Okay, let's get this. So we're talking about aging. And so with aging, you're thinking, well, how long are people living? So the life expectancy, these are the rankings in 2023 where we have the data. And these are the top 10 countries in the world in terms of expected longevity. So coming in at number 1 is Hong Kong, with women surviving an average of 88.7 years and males 83. Then Macau, Japan, Singapore, and South Korea, 5 out of the top 10. So in Asia, people in general are living pretty long, well into their 80s, as you can see, 87 and 80 for South Korea. That comes in, I guess, at number 6 or 7. Sorry, picture 7. Okay. Okay, so you might say, well, how are we doing in the United States? I had to go pretty far down in the rankings. We are number 47 in 2023, with an average age for females at 82.2 and males at 77.3. Okay, let's drill down a little bit to San Mateo County, locally here, right in the peninsula. You can see that between 2016 and 2025, Asians have done pretty well. This is self-reported ethnicity at about 86.4. But just in the past 2 or 3 years, the Hispanic Latino group is doing pretty well and outstretched by 0.1 at 86.5. So again, locally in the state of California, we're doing well compared to other ethnicities. However, as of June of 2025, NBC News came out with an update. US-born Asian Americans are no longer the healthiest group among older adults. Among older adults, non-Hispanic white Americans have overtaken Asian Americans as the healthiest US-born with the lowest rates of disability. So that caught my attention. So I decided to figure out what article are they quoting anyway. And it's this one that was published in the Journal of Gerontology and Psychological Sciences in 2025. And they wanted to look at self-reported disability and difficulty with independent living between 2005 and 2022 compared to other racial groups. So let's just see what they found. And what data did they use? They used data from the American Community Survey, which is a nationally representative survey of the United States population. And it was limited in their analysis to those over the age of 50 who denoted only one ethnicity. This included about 25,000 to 34,000 Asians over 4 periods where they administered the survey. And you can see quite a few more whites, up to 4.8 million, more blacks, up to 500,000 or so, Hispanics at 132 to 17,000, and Native Americans were included in the earlier, for US-born graph that you'll see to the right, about 28,000 to 48,000. So pretty good representation for Native Americans. And what you see in the graph on the right-hand side is the top 2 panels refer to self-care difficulty. And you see that there is a trend downwards, which is actually a good thing. So with increasing years from 2005 to 2020 to 2022, those who reported that they were Black or Native American or Hispanic or white all reported declining proportions of self-care difficulty. Here are the Asians, kind of a straight line, but the lowest amount of self-care difficulty compared to all the other self-reported ethnicities. For foreign-born people, it also showed this similar trend of downtrending. And even amongst the Asians, there's some downtrend of self-reported disability over the years since 2005. Now, many people as they age really do value living independently. So this bottom two graphs are important as well. And what you see is for the US born uh, people, they are seeing a decline in independent living difficulty. So that's great. They're the Asians on the bottom, and they're kind of stable, in my opinion. But foreign born, again, a downward trend for everybody, pretty much, except for maybe Asians leveled out. But this is what these people who published the article and what the media picked up was, well, uh, actually, th that there has been a declining gap, but it's because everybody is improving. So I think that's a really good newscast, and why they decided to put one against the other is a little bit of a surprise to me, because it looks pretty encouraging for society. But given that they said it was US born who were seeing a declining benefit of either mainly self care difficulty, who were the US born Asians? Well, it turns out that the biggest proportion were of the Japanese community born. And you can see they're represented by the orange on the left-hand graph. And then other Asians, which comprise a huge group of different Asians from all over the world, also comprise probably the largest point, with Chinese being at the bottom, and then very little representation from Asian Indians and Korean, with a little bit more with the Filipino groups. But and then foreign born, you can see that later on there's very few Japanese, but increasing numbers of Filipino, Asian Indians, and others, as well as Koreans. So it was really, if they were going to make a big deal about everybody, it's really the Japanese who'd been here for a long time. And so in their discussion, they kind of said, well, what could be causing, increased problem, or not as great health for this US born Asians? Well, it is true that specific diseases sometimes are less common in the native countries, and then with this assimilation, they can become more common within one generation of living in the United States. And a good example of this was breast cancer, because breast cancer incidence in Japan is very low, but within one generation, the incidence of Japanese Americans coming down with breast cancer starts to really approximate white Americans, which last I checked was about 1 in 9. Could be a little, I'm not sure, 1 in 8 to 1 in 10, depending which decade you're thinking about. And it's also true that breast cancer seems to be more common in Japanese Americans versus the Koreans or Chinese. Should also note that breast cancer rates are higher in Filipinos. So in the paper, they talk about, well, perhaps they're having less good self-care because their socioeconomic status looks like it was declining when they looked at that. And the high school graduation rates were actually not as great, although the college graduation rates increased by 10%. So that was kind of their discussion of this. And I don't know, I think that the media may have gotten more excited than anything else, but it was interesting to look at. So thinking about those immigration trends over time, getting a little personal, I am a fourth generation Japanese American. So that's when there was more immigration of the Japanese earlier on in the 20th century. And here is a picture in the center of my great great maternal grandfather, who immigrated from Japan and Tokyo in the early 1900s, learned English at Lowell High School, I understood from my family. That's in San Francisco, went to Berkeley, and then opened a music store, and that's in downtown Sacramento. You can see the picture on the left-hand side. There he is in that picture, though, because when Pearl Harbor was bombed, he was immediately taken to the police headquarters for interrogation, as he was considered a community leader. Also, he spoke English pretty well. And so that was his story. And then on the far right is my paternal grand great grandfather on my grandmother's side, and here he is pictured next to a store. So he was also a shopkeeper in Waimea, Kauai, circa 1914. So my family has been in the United States for centuries now. So I am also known, I'm a geriatrician as well as a gerontologist. And as I've been giving more talks lately, I've realized that many people don't really understand the difference between what a geriatrician is versus a gerontologist. Turns out that also around the turn of the century in the 1900s, these are when these two terms were coined. So on the left-hand side, you see Dr. Elie Metchnikoff, who was a zoologist and immunologist originally from Russia, who is credited with becoming the father of gerontology. And he's probably even more known for being a Nobel laureate because he is the one who discovered that immune cells can eat other cells like bacteria, a process known scientifically as phagocytosis. Through his study of this phagocytosis, he became very convinced that aging is a disease. He thought that they're toxic metabolites that build up in our gut and that lead to diseases and aging, such that I guess he must have observed the Bulgarians who ate a lot of fermented foods, including yogurt, that he changed his lifestyle to eat yogurt on a daily basis to stave off aging. And I find it ironic because I'm a gerontologist, and while I built a lot of my career on musculoskeletal aging, my latest interest is in the gut microbiome and aging. So I feel some kinship with Dr. Metchnikoff. On the right-hand side is Dr. Ignaz Nasher, also from Russia, grew up as an immigrant in the tenement area of Lower Manhattan, went to medical school at NYU, and noticed through his practice that older people really should have their own specialty. They had special needs, and he argued that just like pediatrics, which focuses on the special needs and of medical needs of children, that older people needed this too. In fact, he wrote one of the earliest textbooks dividing, he did not believe that aging was a disease. He felt there was a physiologic basis of aging. He felt that there were diseases related to aging, and he also believed in a lot of social and cultural as well as environmental factors that would contribute to the rate of aging. So there they are debating geriatrics with gerontology. So I'm a geriatrician. A geriatrician is a doctor who takes care of older adults. This question about aging being a disease has been going on for centuries, dating back to the ancient Roman and Greek times, where the Roman philosopher Seneca is quoted as saying, "Senectus morbidus est," aging is a disease, versus the Greek philosopher Plato, who really believed that aging entailed a balanced relationship between the soul and the body. Interestingly enough, in the United States, Wall Street Journal 2025, with the headline, "The scientific fight over whether aging is a disease continues to this day." And our colleague, Dr. Jack Rowe, who comes to Stanford to teach in our longevity course, was quoted in that article as saying, "Advanced age often carries overlooked positive social and emotional changes, such as better problem-solving skills and emotional stability." And Dr. Eric Verdin, who's a geriatrician and leads the Buck Institute here in California, he was quoted as saying, "Treating aging as a disease would mean that everyone who is 20 years old is actually ill." Well, why could aging be considered a disease? Um, well, if considered a disease, understanding the underlying biology of it would be important to discover a cure. And even if it's not considered a disease, it is a common risk factor for cardiovascular disease, cancer, dementia, and other diseases. So people have, and scientists have agreed, if we could understand the biology of aging, we might be able to target a common upstream modulator that could slow getting older itself, and therefore the onset of these age-related diseases. And if you're out there and you're exposed to social media or even the news, there's a lot out on longevity and what can you do to stave off aging. And some of it, some people have termed as kind of snake oil ideas, and this has been going on for centuries. And others feel like now with the sequencing of the human genome, the technologies that we have, we need to lend more credibility to the field of understanding the biology of aging. So scientists in the NIH and the NIA, the National Institute of Aging, came together and developed a new term that they call geroscience, the science of aging, which they agreed should be founded on three basic principles. The first is really the goal is to improve the quality of life for humans, and that age-related diseases are the primary challenge to improving quality of life, especially as we age, because aging is the main risk factor for these diseases. So perhaps if we could slow or reverse it, we could just stave off a lot of disease. It's a great goal. But what some of the scientists felt like, well, they're very curious and they say, okay, here's the blue line, a normal lifespan. And their debates, well, how long theoretically, if we found the cause of aging and we targeted it, could we extend lifespan? And some have said 150 years. I've had one person come up to me and say 600 years. I don't know how they got that, but that's what they think. But a lot of gerontologists, realizing that health and good health is important, started focusing rather than extending lifespan, maybe we should really think about maximizing health while we're alive. And so there's lifespan extension in red and health span extension in the green. And the WHO has gotten involved with this, and they said, yeah, let's think about lifespan versus health span. And so what is health span? Health span is the period of one's life that one is healthy. And though as a geriatrician, I have had trouble with that definition because through my practice, I feel like being healthy can mean different things to different people. The WHO has come across with this age-adjusted life expectancy, health-adjusted, sorry, life expectancy to get at a sense of healthy years versus poor health years. And here you see on the bottom in the United States, as of 2023, it was estimated that health span, the average health span, someone being healthy without chronic disease is about 63.9 years, with a mean lifespan of being about 79. So you've got a good decade or more where people are, quote, living in poor health. So I'm glad that more recently the WHO has come out with another term termed healthy longevity. And I really favor this term because it offers a more flexible definition of what matters to most people. So healthy longevity is important because if you're a basic scientist, a gerontologist, or practicing geriatrician, one thing you know for sure is heterogeneity increases with aging. So here's just a pictorial example of where the picture and the schema of young adults looks more similar. They might be shorter or taller, fatter or skinnier, but very similar. Whereas in older adults, we have just such a range of different health and functions. So healthy longevity is really a heterogeneous state. It is multifactorial. It can vary over time, and everyone could theoretically experience healthy longevity. And so that's good news. And in fact, I show some pictures of my fellow geriatricians here at Stanford and at UC San Diego, where we agree that most geriatricians do not consider aging a disease. And many consider healthy longevity as being a state of well-being. And most believe that healthy longevity does not require one to be completely disease or disability free. And here are pictorial examples of that, such that the person on the left is sight impaired, out and walking around, a few people with mobility issues, still getting out and about, someone who requires oxygen to breathe comfortably, and someone who's hearing impaired. All these people can be quite functional and have healthy longevity. Okay. So hopefully now you're convinced that heterogeneity increases with aging, but now I've delved a little bit away from American Asians. And in fact, we are also very heterogeneous. There are 6 origin groups, this is from the Pew Research Center, that account for US Asian population, with the majority now in 2023 being Chinese at 22%, Indians at 21%, Filipino at 19%, followed by Vietnamese, Korean, and Japanese below 10%, and then all other origin groups at about 19%. And you see the list of all these people from Pakistani, the Hmong, the Cambodian, etc. The other thing is true that with Asians being in the United States and living in a very diverse population, about 16% of Asians are reporting that they're multiracial, with Japanese being 38%, Filipinos 21%, and Koreans 17%. And around 4% of Asian Americans also identify as being Hispanic. So what does it mean to be Asian in America? I would say that American Asian heterogeneity is also now compounded by the heterogeneity of aging. So from the Pew Research Center, I like this quote from a focus group where someone was quoted as saying, I think when I think of the Asian Americans, I think that we're all unique and different. We come from different cultures and backgrounds. We come from unique stories, not just as an individual group, but as individual humans. So let's delve back into that interesting paper from the Journal of Gerontology. They actually did do a breakdown of Asians and self-care difficulty, independent living difficulty. So here they've classified people as Chinese, Japanese, Filipino, other Asian versus white. And you can see there's some variability as over the years from 2005 to 2022. What you see is I guess the first Chinese, the dark black, seem to be going down in both areas. The Japanese also seem to be going down for self-care difficulty, maybe a little bit of independent level difficulty blip in 2010. Also, the same blip is noted for the Filipinos. I don't know what happened between 2010 and 2014, but there's definitely the blip in the wrong direction for these two groups. For whites, they're a downward trend for both groups, but it's really this other Asian population, self-care difficulty, is seen to actually increase as of the most recent survey. So it is really important to think about who are we talking about? Not all Asian Americans are the same, and there may be particular needs of each group depending on their makeup. So when you think about acculturalization or assimilation, if you're born here and you have children here, or if how are our beliefs regarding age changing? And could those beliefs and how we think about aging affect our health? So, according to Becky Levy, who's a psychologist out of Yale, who wrote this book, Breaking the Age Code, she says there are definitely age stereotypes. And I'm sorry, we all have them. All of us have them. We all have stereotypes. And she would argue that these age stereotypes are really internalized across the lifespan, such that they even operate unconsciously. Like we're not even aware of our own biases about age. But they do come a little bit more relevant as you age into being old. So then your own views on aging affect you, and that these beliefs about aging can impact your health psychologically, behaviorally, and biologically. And here's a picture of Japanese children in Japan who they actually have a national holiday. It's called, and I don't speak Japanese, so forgive my pronunciation, Kero no Hi or something. It's Respect for the Aged Day. It's a national holiday in Japan, and it happens to be celebrated the third Monday of September since about the 1960s. And here these children are drawing pictures of their grandparents for school project. Fortunately, since I've been talking about heterogeneity with aging and now heterogeneity amongst Asian Americans, we are in the era of precision health, which is high tech and high touch. And we are here at Stanford in the Silicon Valley. We are well positioned to tackle the heterogeneity issue. What is precision health? It reimagines medicine to focus on predicting, preventing, and curing disease precisely. Now, when I saw this definition come out, I thought, well, that's great, but what if you're aging and aging is not a disease? Could precision health be thought of more as optimizing healthy longevity? So that's what I propose. And I'm going to spend the next few minutes talking about three examples of precision health in operation from an Asian American perspective. So the first example is in pharmacogenomics, which is a relatively new field in the past 15, 20 years. And there's state-of-the-art testing that can now be done in clinic at Stanford, at the VA, and there's a lot of room for continued discovery because it's so powerful. We can do pharmacogenomic testing, understanding your genetic profile as it relates to your drug metabolism to figure out what dose do you need and what medications might work best for you. So for Asian Americans, what is the test used today? Well, it turns out that gout is a problem for Asians, Americans, especially as they age, and such that the prevalence of gout increased between 2011 and 2018, exceeding all other ethnic groups in the United States. And it is already known that there's a lot of genetic variation in uric acid metabolism. So if your uric acid goes up, your risk of gout goes up, gouty attack. And it's noted in certain ethnic groups. And even more concerning is a very common drug used to control gout is allopurinol. And there have been reports of allopurinol leading to deadly skin adverse reactions in Asians that could be terrible. And yet, most doctors, allopurinol is a drug that's been around for a long time, well tested. So they might not even think about it. Just say, oh, you have gout, here's your prescription. Well, the American College of Rheumatology and rheumatologists are the doctors who are specialized in treating gout. They now recommend genetic testing for HLA B5801 in patients of South Asian descent, Han, the Chinese, the Korean, and Thai people, and also African Americans. The schema on the left just shows you that here are a picture of patients with the same diagnosis who actually might have very different responses, ranging from a good response to no response to an adverse drug reaction. So pharmacogenomics is a really exciting area of medicine that is truly clinically applicable today. The second example is going to focus now where we don't have such great precision yet, but we can invoke physician education and expertise to best treat Asian American females to optimize their bone health. So here's a radiographic picture on the left of a normal hip. A typical hip fracture is where I put that blue arrow in the middle where there's a femoral neck fracture. Those are the most common types of hip fractures. But then you don't need to be a radiologist to see the one on the right, which is an atypical femoral fracture that has been found to be much more common in thin Asian and sometimes not so old females. And so these are rare stress fractures that are much more common. And here is from the New England Journal of Medicine 2020, I think out of Kaiser data, that shows that Asian females in particular, I don't think it's just females necessarily in this graph, but have a far higher incidence of getting this weird break of their femoral shaft compared to someone who's Black, white, Hispanic, or other unknown. And it is well known that long-term treatment with the number one drug that is used to treat osteoporosis, a bisphosphonate such as alendronate, is a risk factor for developing an atypical femoral fracture. The take-home message, though, is that bisphosphonates are still the number one treatment, and it doesn't mean that Asian American females should not be getting it. However, what does it mean? As we've known about this since about 2008, it means that we need to not treat people forever on this medication, especially Asian females, and we need to limit the duration of treatment somewhere to between 3 and 5 years. And in Asia, like Hong Kong, Taiwanese, Japanese, I don't know about Singaporean, but my other colleagues who are treating mainly Asian patients who are females, reduce the dose to half of what it's given in the United States. And we know that they're clinical warning signs. So you educate your patient. You say, oh, how are you doing? Don't make them think about thigh pain. But if they complain about thigh pain, you can get a plain x-ray of the femur or the thigh bone and look for changes that may suggest that they're at risk for cracking their femur in half. And the good news is once you know they're at risk and you've gone through your 3 to 5 years of therapy, you can stop the medication, and that risk for that atypical femoral fracture basically goes back down to zero or close to zero. But Singapore, where I got to visit in 2022, they use their number one treatment is bisphosphonate for sure. And but most of the patients are Asian females. So they are now using a technique called DEXA, full length femur imaging. And this is to improve the detection of these AFFs. And it's now offered in the Singapore General Hospital. And it's really tailored just for those high-risk patients, particularly those who have to be on long-term bisphosphonate, or in this case, also denosumab, which is known as Pronelia, another type of therapy that has been linked to atypical femoral fractures. And they have the International Society of Clinical Cytometry, which is our best international society, American society as well, for DEXA quality. DEXAs, in case you don't know, are the number one screening test to test if you have osteoporosis. And so they also endorse this. So here's a picture of what a typical DEXA scanner looks like. And if you were to get that long femur x-ray from DEXA, which doesn't have the same amount of radiation as even a plain x-ray, it's like flying to Singapore in terms of radiation exposure, probably even less because it's really flying to New York as the equivalent from the West Coast. Singapore is a lot farther away. You can see this little ditzel here where it's a beak. This beaking is a sign that this person would be at risk for developing a femur shaft. So you would stop the bisphosphonate in this case. So the third example is Asian community education, like we do here at CARE. And it's an advocacy to promote awareness of health concerns that may apply to specific groups. So we'll finish with this. How am I doing on time? Oh gosh, I better hurry up. Okay, so it turns out that as of July 29th, 2025, in the Annals of Internal Medicine, the top internal medicine journal, is a huge risk for cardiovascular disease, heart attack and stroke, etc. And this is from the CDC Wonder database, which is a national death database from 2018 to 23. And they quote, Filipino Americans, especially men, are at the highest risk of dying from a cardiovascular cause compared to any other American Asian subgroup. And these latest statistics reflect the trends that were previously reported by our Stanford Care group, Doctors Lin and Palapanian. I'm sorry, I can't pronounce her name correctly, from 1994 to 2018. So here's the graph, and it really shows like 248, just remember that number, 248.3 age standardized cardiovascular mortality per 100,000 population. Because here is the report that I found from our care faculty founders. They wrote in their first care data brief in 2020 that in the Philippines, cardiovascular disease accounts for approximately 20% of total deaths and 35% of premature deaths, affecting 1 in 6 Filipinos and 1 in 3 Filipino Americans, compared to 1 in 3 non-Hispanic white Americans. And that the CVD death rate was 393 per 100,000, compared to 192,000 compared to the American population. So if you remember the number I said before, at least from 2018 to 2025, it's a little better than the 396.3. And also they wrote in that report that the percentage of Filipino women undergoing medically necessary treatment, such as bypass surgery, increased from only 3% in 1994 to 51% in 2004. So they also reported that compared to those who were in the Philippines, still 80% of Filipino American men versus 13 drink alcohol. 50% of Filipino American women versus 6% drink alcohol. There are more smokers, however, in Philippines. It's 28 versus 17% in America. But also the average daily salt intake for a Filipino diet is higher in carbs, cholesterol, and salt. It's 12 grams or eightfold times higher than the American Heart Association recommendation of 1.5 grams of daily salt intake. Here's a picture, though, from Iriga City where in the culture in the Philippines is very strongly felt to honor your elders, and that this is what this picture is showing. So there's definitely cultural facets that also affect our health, and I thought that was a really nice statue. So finishing up, what can we today for all of us and Asian Americans? We know that what you eat matters. So specifically for Asians, what was the study that I could find? Well, from China, a longitudinal healthy longevity survey where the mean age was about 90 for men and 93 for women, almost 9,000 people studied from 1998 to 2011. And basically what this shows is if they have a healthy lifestyle score, that means do you eat fruits, do you eat vegetables, and are you physically active? You can see that there's improved survival compared to not doing those things. And the red versus blue is chronic diseases versus non-chronic diseases. So again, this idea, you can live with chronic disease and still have healthy longevity, and those people are looking that way. And here, the bottom part is basically saying don't smoke. But interestingly, it's really those people who have chronic diseases who get the best benefit of stopping the smoking. The next thing, so you heard about diet a little bit, fruits and vegetables. What about physical activity? And I'd like to point out that many of the traditions have originated in Asia. And the proverb from Japan is only staying active will make you want to live 100 years. And here are just some examples of populations in Asia doing Qigong, yoga from India, Radio Taiso from Japan, and Tai Chi from China. But here are the data. This is US data for the NHANES, not broken down by race, but basically saying being sedentary is not good for you. And so the percentage of time sedentary should really be less than 50% of time if you really want to survive well. And hours of sedentary time, definitely don't spend more than 10 hours of your waking time being sedentary. And this was, in this study that was published, they had people wearing actigraphy monitors so they really could get down as to how much people were moving. And then on the right-hand side, it comes out of Taiwanese data of 400,000 or so men and women. And they just wanted to ask the question, how much activity is really needed to maintain health? And they came to the idea that actually more activity is better, but even just 15 minutes a day will improve your mortality risk by reducing it by 14%. And you can see the curve just goes up. And for those who really want to be vigorous, you get a big bang for your buck. As a geriatrician, seeing patients sometimes into the late 90s, I really like to say to everyone who comes in the door that these benefits of exercise and changes in lifestyle can really improve your life at any point practically. So here is the picture on the left of Chen Chi Feng from Hong Kong. She was a factory worker, not really an exerciser at all, but she had fatty liver, high blood pressure, and cataracts. And then because she had retired, she decided to work with a trainer to get fit. And at age 70, she was very happy to report that all of those things listed are no longer a problem for her. And Charles Zugster is from the UK and made the press over there because he just started running at age 95. And I think I'm at the last slide. So when preparing for this talk, I've kind of thought by learning about these different cultures that in general, there's a lot in the philosophy and the culture of Asia that really has thought about aging as a natural process. And I just list some of them there. And that perhaps that can be part of the explanation that there are 5 out of the top 10 longest lived societies in the world. But with that, I'd like to leave some time. I guess we have 15 minutes for questions. Thank you for your attention.
Thank you so much, Dr. Kado, for such an amazing and insightful presentation. There's definitely a lot to learn about Asian American longevity. So it seems like we have a few minutes for questions. We'll start off with one of the pre-submitted questions from the audience. So the first question is, what specific health challenges do Asian populations face as they age that differ from non-Asian populations?
Yeah, so I'm going to focus on American Asian populations just to be clear, because we're living in America. And I think what we suffer from are those aging related stereotypes, right? And so it's the self expectation of what we think is possible, as well as your healthcare provider. So many times as a geriatrician, this is why I feel people like to come to geriatricians, because especially in the Asian cultures, one thing great about Asian cultures is oftentimes the children will come with the parents to the appointment. But then when that happens, sometimes the doctor then just talks to the child, the adult parent, as adult child, as opposed to the patient. And I think that's detrimental to care. It disempowers the person who's supposed to be taking the patient. And I think that our culture kind of allows that. So it's that age where people are kind of looked past. And then because of our family nature, and it's not always true, there's often another person in the room, and then the patient themselves gets ignored. And sometimes it's a language barrier, but we have interpretations. So Stanford Healthcare really focuses on trying to encourage people to use an interpreter for a patient rather than going through a family member or a caregiver, for example. And then doctors' expectations. So doctors also, I tell this story. I had, when I was still seeing patients at Stanford, I had a colleague whose mother became my patient, and I happened to see the patient. Patient asked, told me that she had had some back pain, so I decided to transmit that comment to my colleague, who then said, "Well, what do you expect? She's old." So I think it's that dueling thing of trying to really accommodate differences in understanding Asian individuality, as well as the challenges that people face in terms of societal expectations with people getting older.
Thank you so much. The next question we have is regarding traditional Chinese medicine. It says, what do you think of traditional Chinese medicine for treating age-related conditions? Are there any concerns about contraindications or contamination?
So that's a great question. So first of all, I'm not an expert in traditional Chinese medicine, but I have interacted and cared for patients along with practitioners. I think there's some real benefits in terms of this comes from centuries long tradition, right? And part of it is the beliefs that you're going to get better, that help you get better, and the touch, the acupuncture, the kind of understanding of bodily functions. So often, whatever is the pulse in 27 different ways, or the reading of the tongue architecture. I'm not going to debate those. I think my concerns regarding traditional Chinese medicine is sometimes those supplements, we just don't know what's in them. So FDA has its own problems of not regulating supplements. That's a whole nother talk. But in China, I think ever since that report came out that there's melamine in infant formula, made me very distrustful in general. So unless you really know what the herbs are in a very clear sense, I would probably err on not taking them. Because first of all, we don't have the kind of gold standard data to say that they work, but I think they're built on good theories. It's just that I worry about contamination, absolutely.
Mhm. Yeah, thank you for sharing. Another question we have is, what caretaking resources are available, such as financial support for family members who stop working to provide care?
Ah, that's a great question. So this is why geriatricians love and have social workers to work with, because they know the local resources, and they're actually county resources too, and the websites. I actually went to Rockville, Maryland, and was surprised that every state has an aging um, resource to provide information about what local services are available. But in general, because I've lived across the states of California, it's very regional specific. But if you are Medicare and Medi-Cal, one can obtain what are called in-home support services so that if you're not working, you can get payment for those services for a limited number of hours that help. That being said, the administration is changing everything. So it's just Meals on Wheels is something that's not necessarily financially based, but if you have trouble accessing food, getting food, that was something that we could offer in Santa Clara County and San Mateo County for people, regardless of ability to pay. Some people can, some people can't. So anyway, uh, so local websites, your care practitioner, social worker, things like that, you'd be amazed at what you can find, and word of mouth.
Yeah, thank you. There's been a few questions regarding blue zones, actually. So how do Asian American longevity factors relate to those from blue zones? Are there specific epigenetic biomarkers that are more prevalent?
So great. So the blue zones are great with Dan Buettner, and these are really not formal research studies as much as observations, or sometimes we call them ecologic studies, where they're unusually long-lived individuals in certain areas of the United States, or sorry, of the world. So the first three blue zones, in case people haven't heard of them, were actually, I'll just start with Okinawa, Japan, but then there was Sardinia in the Mediterranean, and then Loma Linda, California. And when people looked across these different cultures, there were certain types of characteristics that were common. So one was diet, generally it didn't have to be the same diet, but fruits and vegetables, non-processed foods, activity and purpose in life, community, all of those things. So were common, and there are more, but those are the main things. In terms of epigenetic markers, there are studies that are going on about that, but you might hear of things like telomere length or epigenetic DNA methylation clocks. But I would say those are really not ready for prime time and have not been necessarily helpful in helping a clinician figure out prediction in an individual's life and how they should live. But the research is going on.
Hmm.
Yeah, and they're hypothesized
Yeah,
markers.
thank you. I'll go move on to some live questions we have in the chat. Tony asks, could you elaborate the causes for increased breast cancer in Japanese Americans in America? How does the environment worsen the risk?
So that's an interesting question. Now, these are papers that I remember from the 1990s, so it was a long time ago. But what you do see is a gradual change in diet. So that's one. Also, if you get to be in Japan and you come here to California, for example, in Japan they have amazing public transportation, but you usually have to walk to the transportation. There's a lot more walking every day. You put in a lot of steps. California, not so much. We were built on highways, and public transportation pretty much is not very good. So you could point to those two things alone. I haven't looked at, there is an alcohol risk to cancer as well. For Filipinas, that was also noted that there's much more drinking in Filipino Americans versus Filipinas who are from the Philippines. So, and we know that alcohol is a risk factor for developing breast cancer. I haven't looked at the studies to see if drinking behaviors differ between the two groups, but I'm going to suspect that they actually do.
Hmm. And on the topic of women's health and breast cancer, Michelle asked in the chat, are there any thoughts on menopause and how it may differ for Asian Americans versus Asians in Asia?
That's a really interesting question. Now, I was going to say we have a national NIA funded study called SWAN, where it was the studies of women across the nation, include Chinese and Japanese versus whites, Hispanics, and Blacks. And I was going to say Asians in general have fewer symptoms of menopause, I think, than other counterparts. How it is differs in Asia, I am actually do not know the data in that regard.
Yeah, thank you. Another question, how does the transition from lifestyles adopted in Asian communities to American lifestyles impact immigrants' health?
Well, one thing I noticed when I came to Stanford and I was still doing the bone clinic, I had quite a few older Asian patients, mainly women, who had very low bone density scores. So they didn't want to start on the medicine maybe, or they got sent to me. And what I noticed, and these were often non-native speakers or didn't speak English very well at all, that while their bone density scores were not good, and I asked them to do what I do, which is, watch them get up off out of a chair and test their balance, uh, look at their posture and their strength. And what I noticed overwhelmingly, and these are mainly people who were from Taiwan and China, I think, uh, they were not just doing that, they were squatting down to the floor. And my white counterpart patients, they were afraid to get anywhere near the floor for fear that they couldn't get up. So I feel like that how they grew up and their ability, maybe they did Tai Chi. Sometimes they did. Sometimes they had done it in the past. Sometimes they had never done it. But certainly, I think the cultural activities in China lent for more getting near the floor compared to to what we're all sitting in chairs, and then you come and you move to the United States and you go to a restaurant, you're definitely sitting in a chair. You're not sitting on the floor. Yeah.
Yeah. One last question. I think this is a good one to end off with. It says, given that there is still a lack of understanding regarding the unique experiences of Asian Americans, especially in treatment among practitioners, how should Asian Americans be approaching physicians who may or may not be well versed in the latest research on Asian Americans?
Yeah. I think hopefully you have a physician who's open to listening. I think that's like number one, and that you can bring up those particular concerns that you might have, and also to be informed yourself from reliable places like CARE, or, there's so much. I just got from a Stanford colleague today a text about something they had seen on Instagram, and should they be using this particular thing for their bone health? And I'm thinking, don't listen to Instagram. Don't go on YouTube. They're going to tell you to buy this potion and it's going to cure your disease forever and you're going to look young forever. No. But I know they're so good at marketing. You feel like, oh, it shouldn't cost that much, money back guarantee. I don't even click because the science is just not backing up. So really pay attention to where your sources are. So CARE is a great resource, I think. Medical journals, but they're a little hard. But there are a lot of resources that try to translate the science that are so short newsletters. It used to be the CDC. The WHO has a lot going on there. The Pew Research Center, you can learn more. And so being educated yourself can help you hopefully educate your doctor if they're just so busy and they just don't understand the particulars of your particular concern, say like gout. Yeah.
Yeah. Thank you so much. All right, due to limited time, we'll have to wrap up here, but Kara can definitely direct all of your questions in the chat and then Q&A to Dr. Kado, and we'll send out an email with all the detailed answers. As a reminder, just to fill out the post-webinar survey that Nina has sent in the chat, as we value all sorts of feedbacks from our audience. And Dr. Kado, thank you so much for your time and for speaking on such an important topic. And thank you to our audience as well for joining us this evening to learn more about Asian American aging. We hope you can join us next month on October 7th for another Care Community Health Talk on cancer and chronic disease risks in Asian populations. Thank you so much, everyone, and have a wonderful night.